Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Servier.
Welcome everyone to today's program. So the topic of the discussion today is the evolving landscape of IDH-mutant glioma management and how the standard of care can and should be redefined. We have a wonderful panel. I don't need to read their credentials. They're all well known, and a very full agenda. So we'll get going. What makes me especially excited about today's discussion is the fact that the things we're going to be discussing today are reflecting more than 2 decades of scientific work. And it is the result of our better understanding of the molecular drivers of gliomagenesis. That starts with the IDH mutation story going back in 2008, where IDH1 and 2 mutations were identified as key drivers in glioma development. The mutated IDH oncoprotein causes accumulation of the 2-hydroxyglutarate oncometabolite, and that triggers a number of changes in the cell that stimulate cell growth and glioma development, including epigenetic dysregulation, blocking of cellular differentiation, impaired DNA repair, and of relevance for some of the discussions we're going to have later today about future directions, also increase immunosuppression. So if we think about gliomas in general, what percentage of the gliomas have an IDH mutation? Well, that's not a polling question. I'll give you the answers. Approximately 20%. And of gliomas with IDH mutation, the majority, 90%, have the IDH1 R132H mutation. So it's about 90%, and the majority, the remaining 10%, having the so-called non-canonical mutation. So other less common either IDH1 mutations or IDH2 mutations. Now the good news is that there is a very good immunohistochemical method to detect the most common IDH1 mutation, should be available in all your institutions. The remaining 10% requires next-generation sequencing, PCR, methylation profiling, other technology to be able to detect. This realization of both the prognostic and predictive importance of the IDH mutation led to its incorporation in the revised WHO 2021 classification for adult diffuse glioma, where characterization of the IDH status became a required testing for the characterization of the gliomas as part of the integrative classification. As we discussed, we have IDH wild-type glioma, specifically glioblastoma, and IDH mutant glioma. And under this umbrella, depending on other molecular alterations, we have the astrocytomas and the oligodendrogliomas, and the diagnosis of oligodendroglioma, in addition to the IDH mutation, requires the 1p19q codeletion. So what are some of the characteristics of patients with IDH mutant gliomas? In general, these are younger patients. You see their median age of the presentation, third decade of life. So in the 30s for grade 2, 3 astrocytomas, in their 40s for the oligodendrogliomas. And the majority of patients are asymptomatic at presentation, except for seizures, which are usually well controlled initially. So if we think about optimal management of our patients with this disease, keep in mind these are young patients. In general, they have good prognosis. Some of the recent advances, hopefully they're going to improve the prognosis even further. So they will live for decades. As such, it is important to consider not only how long they're going to live, but also their quality of life, their social, physical, and cognitive functioning, fertility issues, other issues we're going to be discussing later today. If we think about optimal management of patients diagnosed with IDH-mutant glioma, first I would start with surgery. And the only thing I'm going to say is that at the time of diagnosis, surgery is recommended and maximal safe resection is the goal. I'm not going to say more there because my colleague, Dr. Harvey Jumper, will be discussing more about that. For low-grade glioma who are high risk at diagnosis, we know based on the results of two large trials, RTOG 9802 and the ECOG Akron E3F05, that addition of chemotherapy to radiation significantly prolongs survival versus radiation alone. And the type of chemotherapy used in RTOG 9802 was PCV, procarbazine, cysteine, UMB, Kristin. You can see here essentially doubling of median overall survival from 7.8 to 13.3 years. And very similar results with use of temozolomide in the ECOG Akron E3F05. Now, you see here at the title, high-risk low-grade glioma. These studies were designed back in the 90s or early 2000. Back at that time, high risk was defined age older than 40 and less than gross total resection. I want to say here that our risk definition has evolved since, and this is one of the topics we're going to be discussing later in association with our case presentation. Now, how about grade 3, so high-grade IDH-mutant glioma? There we know that the use of chemotherapy in addition to radiation following surgery, of course, is the standard of care. What type of chemotherapy for oligodendroglioma? The most conclusive level 1 evidence we have is deriving from RTOG 9402 and EORTC 26951, where addition of PCV to RT significantly prolonged survival, again, doubling of the median overall survival. And for newly diagnosed grade 3 astrocytoma, based on the Catnon data, we know that use of adjuvant temozolomide for 12 months after radiation therapy significantly prolonged survival versus radiation therapy alone, median overall survival based on the second interim analysis of approximately 7 versus 4 years. And this results was primarily driven by the presence of IDH mutation in these patients. And of course, recently, we have a new regulatory approval in this space. This is the potent IDH1/2 brain penetrant inhibitor vorasidenib. A number of regulatory approvals, starting with the United States in August 2024, and now obviously European Union, Canada, Australia, Switzerland, United Kingdom, Brazil, Japan. So no matter where you are in the world, chances are you're going to have an opportunity to use vorasidenib in your practice for IDH mutant patients. And of course, that's the topic, one of the topics of the discussion today. Now, as you may have noticed, the regulatory approval is across the world for grade 2 IDH mutant gliomas. And also I will highlight it's not just for adult patients, but also adolescent and young adults, patients older than 12. So how about patients with higher grade tumors? Also, how do we combine vorasidenib and other IDH inhibitors with the standard of care, such as RT chemotherapy, as we discussed, and in maintenance treatment? What is the efficacy of other IDH inhibitors, such as ivosidenib, olutasidenib, and safusidenib? And also, because of the discussion we already have and the association of the IDH mutations with immunosuppression, what would be the role of these inhibitors in immunotherapy strategies? And furthermore, can we target in the IDH mutant protein in vaccine development? So all of them very fascinating questions. So without any further ado, I turn the floor to my colleague, Dr. Peters, to start this discussion.
Thank you so much, Dr. Galanis, and thank you everyone for being here today. So we're really going to talk now and delve into the IDH inhibitors and what is happening in this space. And then for the treatment of low-grade gliomas, Dr. Galanis has already explained sort of the paradigm of how we treat these patients. And really the traditional was that patients were put into either a high-risk category, which was defined by having a subtotal resection and being older than the age of 40, or having a low-risk category for those younger patients and having a gross total resection. If you were high risk, then you would be really go towards treatment with radiation chemotherapy, where if you were low risk, there was the opportunity for observation. But now we've moved forward with new medications such as vorasidenib, and where did that come from? So probably the most important trial that I like to mention first is really the perioperative evaluation of the ivosidenib, which is a mutant IDH1 inhibitor, and then vorasidenib, which is a mutant IDH1 and 2 inhibitor. And this is in patients that had recurrent low-grade glioma that was IDH mutated, that could plan to go to surgery on recurrence. And in this study, what we found and on these waterfall plots is that both vorasidenib in the blue and ivosidenib in the green could essentially reduce tumor growth. So you can see that most of them actually had a response, and there was a positive response for both drugs. And they also found that when they took the tumor tissue out after patients received pre-operative vorasidenib and then they ended up having surgery, that they were able to suppress 2-HG levels. So again, this drug now is rational and was able to hit its target. So it's able to hit its target. The drug was able to reduce tumor volume or tumor size. But because vorasidenib was much more brain penetrant, it was essentially decided that that would be the lead compound to go forward in the pivotal phase 3 Indigo study. The Indigo study design, I'm sure many of you have already read the paper in the New England Journal of Medicine. These were the key eligibility criteria. It enrolled patients that had a mutant IDH1 or 2 glioma, WHO grade 2 by WHO 2016 guidelines, and they had to have a measurable non-enhancing lesion and could not have substantial enhancing disease. And they could not be in need of needing immediate chemotherapy and radiation. 331 patients were randomized in a 1-to-1 fashion to either vorasidenib versus placebo, and the primary endpoint was progression-free survival. If patients did progress, they were able to be unblinded, and if they were receiving placebo, cross over to the other arm. This was the initial data that was published, which showed vorasidenib's superiority over placebo in improving progression-free survival in patients with IDH-mutant low-grade glioma. The median follow-up was 14 months, and because of these results that were published in the New England Journal of Medicine, it was granted FDA Fast Track designation, and it was FDA approved for patients who have WHO grade 2 IDH-mutant gliomas. There was a recently published secondary analysis which further cemented that this, on longer term evaluation, that progression-free survival continued to be extended for patients that were on vorasidenib versus placebo. Also, a key secondary endpoint was time to next intervention. This is time to when they needed more surgery, going to radiation and chemotherapy, or other further interventions. And that has not even been reached. The median value has not been reached for patients that were on vorasidenib versus placebo. And so you can see these updated data here. So these are very encouraging that on primary analysis and then on secondary interim analysis that both progression-free survival and time to next intervention were improved in patients receiving vorasidenib versus placebo. It's very important to note that this drug is very different than classical chemoradiation. Dr. Galanis mentioned radiation therapy. She mentioned PCV and temozolomide. All of those have a series of side effects and toxicities associated with them. And it's very key to note that the safety profile for vorasidenib is very different. It does not cause the cytopenias, the nausea and vomiting that we see with classical chemotherapy such as PCV and temozolomide, and does not cause the late-term cognitive function that we would presume associated with radiation therapy. It does cause an increase transiently in liver function tests. So part of the guidelines to prescribe this medicine is actually to monitor those liver function tests. Whenever I think about this, I think about the most important part that only 3.6% of patients had to discontinue vorasidenib for any kind of treatment emergent adverse event. Moreover, there were no fatal treatment adverse events in this clinical trial. And so this is what we're doing now in practice for our patients. We talk about the endpoint, which is progression-free survival, but I think it's really important to find out what's happening with the patient, okay? What's happening in their lives. And Dr. Galanis has already, touched on this, is that these patients, even though they're young and presumably healthy, they do have seizures. And these seizures can occur at presentation for about a third of our patients and through the disease trajectory up to 75% of our patients. And these seizures alone can cause a loss of independence because they can't drive, maybe they can't work. But then there's also the psychosocial distress of having a brain tumor. And when is it going to come back? And when is you're monitoring this on an MRI, when is essentially the shoe going to drop that you're going to need radiation and chemotherapy, that you're going to need more surgery? Is there something we can do to actually improve progression-free survival? So during the whole surveillance period, we want to, treat our patients that are having seizures because we know from really nice work that has been done in the past that patients with mutant IDH glioma are more prone anyways to having seizures. But unfortunately, that treatment of seizures, anti-seizure medicines, have a whole host of side effects, including fatigue, mood disorders, cognitive impairment. And we also have to think if we did have to give chemo to our patients, I've already mentioned before what the side effects could be. And then there's also the long-term consequences of radiation therapy, which would be cognitive dysfunction. So many of you who are providers and are taking care of patients with neuro-oncology, it doesn't start just after diagnosis. It's all the way through the continuum in watching these patients and dealing with what's going on, not just on their MRI, but what's happening to them day to day. So what was very important in the Indigo study is that I've mentioned the primary and key secondary endpoints, but embedded into that clinical trial, and I think this is very important, where there are exploratory metrics to evaluate health-related quality of life, neurocognitive function, and seizures. And I'm not going to go over this entire slide, but essentially there was a series of metrics that were used to evaluate these. For health-related quality of life, it was for patient-reported outcome questionnaires. For neurocognitive function, it was a series of cognitive tests. And for seizures, that information was garnered by looking at patient-reported diaries for those patients. And when we looked at seizure outcomes for these patients, it's really important to note that patients that were enrolled in the Indigo study could not have uncontrolled seizures. They could not have failed several regimens of anti-seizure medicines. So most patients came into the study with controlled seizures, but invariably those patients, because they did have mutant IDH glioma, they're going to have seizures. So they did an evaluation of patients that had at least one seizure during the clinical trial. And what they found, it was remarkable that patients that were on vorasidenib versus placebo had much less seizures than patients that were on placebo. So you can see that the difference was 1,541 seizures in the vorasidenib group versus 5,124. Um, what was interesting about this is that when you looked at the forest plot for the Indigo study in regards to other survival metrics, there wasn't a difference between astrocytoma and oligodendroglioma significantly. But for seizure control, there was. Patients with oligodendroglioma enjoyed a greater benefit of seizure control with vorasidenib versus placebo than our patients with astrocytoma. For quality of life, what we found is through a series of patient-reported outcome questionnaires, there was no decrement in quality of life over time for both patients on vorasidenib versus placebo. And this held true also for cognitive testing in a series of modalities across all different domains of cognition. So when we think about this and we think about the secondary and exploratory endpoints, if our patients are having fewer seizures, can this really provide them more independence? Are they able to go back to work? Are they able to drive now? And also, if we have patients where we improve progression-free survival and we improve time to next intervention, are we going to actually improve that psychosocial distress that is so inherent in our patients because of they will have less of a fear of recurrence, and can we improve their psychological well-being? And this is so important for all the patients we take care of. And then we need to really note that these IDH inhibitors are extremely well tolerated. They did not impair quality of life in our patients or cognition. So we can really, they can enjoy sort of these longer term and be on this drug longer term because they don't have those impairments. So this is not just about vorasidenib today. There are other drugs that are in this space and are looking to see where they belong in the treatment of our patients with IDH-mutant glioma. Ivosidenib, I mentioned before, it's already FDA approved for AML and cholangiocarcinoma, and I've listed the common toxicities here. It's important to note that all these drugs are oral, and that's in contrast to maybe some of the drugs that we used in the past that are IV for our patients. Insidenib is also for mutant IDH2 patients. It's approved for AML. Olutasidenib is also another drug that's approved for AML. Safusidenib, you probably have seen a recent paper on this, and Dr. Prusser is going to go over more of this in detail, but this is a very interesting drug that's being evaluated in higher grade astrocytoma. And then the two other drugs that are also being evaluated have been evaluated in basket studies. So there's still, even though we've learned a lot and we now have a secondary interim analysis, I'm sure many of you and I, and a lot of us on this panel, have a lot of questions. What happens after progression on IDH inhibitors? How do we treat those patients appropriately? What further therapies will see improvements in time to next intervention? How can we combine these therapies? And Dr. Galanis has hinted at that. And then, because these are younger patients, what about the fertility considerations for both male and female patients that are put on these agents? What are those fertility concerns? And then, because these are long-term medications, what are the associated financial implications for long-term therapy? And then finally, how do we treat patients with higher grade or enhancing tumors? But before we get to all these questions, we're going to delve into the surgical aspects with my colleague, Dr. Herbie Jumper.
Incredible job. Thank you so much. I'm Sean Jumper from University of California, San Francisco. It's an honor to be here. We're going to talk about the evolving role of surgery. What do we know? What do we not know? And there's some new data in this space that I think it's worth talking through. But first, let's start with where we've started, right? We begin by talking about, again, what constitutes an IDH-mutant glioma, right? What is our histologic and molecular characterization? And we see these are the images that we see of patients in our clinic each and every week with WHO grade 2, IDH-mutant oligodendroglioma and astrocytoma, in part based on 1p19q intact or co-deletion status. But as we progress, we remember that we started off with a almost purely histologic definition based on nucleotypia, fried egg appearance histologically, and others, and moved based on the IDH1 and 2 mutation discoveries into more of a molecular diagnosis informed by DNA methylation status, targeted next generation sequencing, which has landed us where we are now. So all IDH mutant diffuse gliomas now are really considered a single tumor type as opposed to astrocytomas or oligodendrogliomas. And then we kick out based on CDKA2B mutation, those folks into a WHO grade 4 status based on some other histologic features. And these are the histologic definitions that we all know so well. The role of surgery in neuro-oncology, again, has been part of the discussion for many years, and the role of the surgeon has evolved a little bit. And we know, and this is a really beautiful slide that's been put together and discussed in a few contexts. I kind of think of it in terms of phases. Phase 1 being the early stage as surgeons as kind of gatekeepers only. Stage 2, where we think about instituting and guiding standard of care with imaging surveillance. And Phase 3, where we really transition into more of the multidisciplinary discussion, where at each step along the way, from presentation to extent of resection discussions to maximum resection, molecular diagnosis, what do we think and how can we improve the lives and survival of our patients through lesion, surgical resection, cytoreduction, and we have some more and more evidence to help support this. On the left side of the screen here, you see a paper that has really helped inform our conversations in our clinic about who should have surgery and how much surgery to give, right? That's the really big question. And this is the left where you could see where we kind of separated patients into two cohorts based on patients at one institution and validated at a separate institution. And the survival outcomes are based on two different types of analysis. First, using recursive partitioning analysis, and then proportional COTS regression models that we'll go through in a minute. But you can see this is our first delve into looking at resection of not just what we can see by imaging in terms of the flare signal, but what happens to patients when we begin to think about resection outside of the flare lesion. And you can see, again, if you use simply the distinctions of GTR plus, which is resection outside of the flare lesion, gross total resection, which is just a complete resection of everything we can see in the flare, relative to GTR minus, anything less than that, that gives us these Kaplan-Meier curves. And we can see, again, not only is there a survival benefit for all comers with greater extent of resection, but the point I bring out in my clinic when I talk to all my patients is a difference between a complete resection and an incomplete resection really doesn't branch until about a decade of time using some of these earlier papers. And so that informs, again, these are younger patients, family planning, lots to do. How much risk do we put them through? And this led to a lot of the consensus guidelines in which, again, we know that maximum safe resection is really the starting point, not just for tissue characterization, but also to improve survival outcomes. This is going into this a little deeper. These are the Kaplan-Meier curves associated with the recursive partitioning risk groups, risk group 1, 2, and 3. And to the far right, you see the longest survival folks. These end up being patients with astrocytomas that are smaller or more completely resected, or anyone with an oligodendroglioma. And the group to the left, the folks with larger astrocytomas, less extended resection, bigger tumors in general. And again, that led to this conversation about how much tumor, what's the minimum amount of tumor that offers a survival benefit for our patients. And this propensity matched scoring analysis here to the left side of the screen, in which you bend patients into 60% extended resection to 100%, and you can see where the survival benefit truly begins at about 75%. And so when a patient comes into clinic and has maybe a large tumor, the question really is how safely can we remove at least 75% of your tumor? You can do the similar calculation with volume of residual, but these sort of discussions are what comes out in terms of both short and long-term neurologic cognitive ramifications of any sort of treatment that we would describe. But this conversation about categorizing extended resection really led to trying to give better terminology around how much tumor is removed. And this is a beautiful paper put out by Philip Karsayev several years ago, in which now he says, well, let's maybe talk about and categorize patients as having let's say, a super complete resection where all of the flare lesion that we can identify is removed, or a biopsy-only resection, which led to work a multi-center, multinational effort now with 16 centers, something called a renal resection consortium, in which many of us around the country, around the world, have put our data together to try to understand what these risk groups look like and what this looks like for patients. This project is actually soon to be published in a couple of months, but what we're showing here is actually the ASPO published guidelines. So we can anyone could look that up before we're waiting for the final publication. But you can see here that the categorization of a class 1 tumor is anyone with a super complete resection, meaning removal of tumor outside of the flare, down to a class 4 resection, which is a minimal resection of flare with lots of residual disease. And you can see the survival curves associated with it. But a couple of other features of this 16-center study came out. Well, first of all, now we're talking about almost 1,500 patients, newly diagnosed, IDH wild type and mutant, over roughly a 20-year follow-up period. And we can see again, class 1 through 4, with a super complete, but we can see again now that the 10-year survival rate for somebody with a class 1 resection in an IDH mutant tumor is 97.5%. For a class 2 tumor resection, again, under 5 cc's or centimeters cubed of tumor remaining, you have roughly 82% 10-year survival. Class 3 is 75%, and class 4, it's really about 50%. Again, soon to be published data. For me, one of the most important prognostic significant parts of this conversation is the upper part of this screen, where you talk about, again, what's the benefit, where these survival curves begin to split for our patients. And again, if you have a patient with an astrocytoma for a complete or extensive resection, those survival curves begin to split after about 3 years only. While patients with an oligodendroglioma, those survival curves split. It takes a little longer. It's closer to 6 to 8 years to see the benefit of a more aggressive resection. And so the key take-home points really are that extensive surgery is this clearly show evidence of greater benefit even earlier in patients with astrocytoma. The supramaximal resection translated into a survival benefit. Now we know both for patients with astrocytoma and oligodendroglioma, which is different from prior. And then we have to think about what are the tools and how do we do that safely in the operating room. That's not the purpose of today to go through each of these strategies, but we'll say we have everything from fluorescence guidance tools to confocal imaging platforms, including stimulated Raman histology, navigation, ultrasound, all different ways we think about trying to remove these tumors as safely as possible to limit the burden for patients. I'm particularly excited about some of the evolving decision support, I would say the tools using optical imaging strategies. This is a beautiful paper put out by Todd Holland in a follow-up paper called Fast Glioma that came out 2 years later, in which, again, using label-free techniques in confocal imaging or stimulated Raman histology, this is the Raman histology option, you can define molecular status, particularly for IDH, and several others, but particularly IDH and MGMT promoter methylation, really as point of care within seconds in the operating room. And so we can define how much risk to put a patient through really as a point of care so that we can decide what to do from there. So this really informs this evolving strategy that we'll talk about for the rest of the rest of the session here. Again, for patients with IDH mutant versus IDH wild type tumors, we know resection matters. We know that we have to have these very complicated discussions with patients if everyone should have a gross total resection or not, based on quality of life concerns. Where's their tumor? What's the patient's willingness to go through the risk and recovery? if we can get a gross total resection, many times it's active surveillance. However, we'll talk about other options we have based on the presence now of IDH-mutant inhibitors in clinical practice. So with that, we'll hand it over to Mateus for where we go from now.
Thank you, Sean. I'm happy to be here. My name is Matthias Beuys. I'm a medical oncologist based in Vienna, Medical University of Vienna, and I'm happy to discuss some future directions in this field. We've heard that we have a lead compound, vorasidenib, which really advanced our field when it comes to the treatment of IDH-mutant gliomas. But as any research, any good research, we have some answers, but also the data we see provide more questions that we want to address in future studies. Some of the questions that I think are very important to address at the moment are other patient populations that may benefit from IDH inhibitors. I'm thinking about patients with so-called gross total resections. I'm thinking about patients treated with radiochemotherapy. So does IDH inhibition provide the benefit when given as a maintenance treatment? And I will briefly show you a design of 2 large phase 3 trials which will address this question. And of course, the important question, what happens after recurrence on IDH inhibitors? What about the safety and efficacy of combining IDH inhibitors with other therapies? And we will look a little bit into this topic. Also, how to optimally manage patients who are treated with the currently approved IDH inhibitor, vorasidenib, and other approaches of targeting this oncogenic mutation. We've heard already in the talk by Dr. Peters that there is not only vorasidenib, but also a number of other IDH inhibitors under clinical development, most of them in early phases of clinical trials. But 2 studies that have also recently been reported, I would like to highlight on a novel IDH inhibitor called savocitinib. And there is quite an interesting paper that was published in Nature Medicine very recently, again looking at this drug, like was similar to what has also been reported for ivosidenib and vorasidenib in a perioperative setting. So 10 patients in this case, received this drug prior to being resected, and the investigators looked at the effects of this drug on the tissue level, but also patients received the drug after surgical resection, and some responses to treatment were reported. You can see here on the left lower corner that indeed hydrogen 2-hydroxyglutarate decreased in the patient samples, and also following up the patients, some decrease of tumor volumes were observed, thus indicating that this drug is also an effective option. Also, a phase 2 study has been reported, which has been conducted in Japan with savocitinib, where 27 patients were exposed to this drug. And you can see in these waterfall plots that responses were seen in the small study with a response rate of around 44%, thus indicating again that there is some activity, although these trials, the trial data that we have so far are relatively small and will need to be followed up in larger studies. There are also ongoing clinical trial efforts trying to develop vorasidenib in other indications that are not covered by the Indigo study so far. Also looking at how to combine vorasidenib with other drugs, for example, immune checkpoint inhibitors, for example, vaccines, and also chemotherapies. And 2 trials, the 2 on the bottom of this table, I would like to highlight, because these are large phase 3 trials which are about to be activated. One is being run by the Alliance group, led by Dr. Galanis, and the other one by the EOTC group in Europe, led by myself together with Marjolein Gertz. In the VIGOR trial, the EOTC trial, we will look at maintenance treatment of vorasidenib after first-line chemoradiotherapy for IDH-mutant grade 2 or grade 3 astrocytoma. We call this trial the VIGOR trial. It's a randomized phase 3 trial, placebo-controlled and triple-blind. This is the study design. We will include astrocytomas grade 2 and grade 3 who have had at least one prior surgery for glioma and who have completed the first-line chemoradiotherapy with the last chemotherapy dose given between 6 and 12 weeks before enrollment. We will randomize patients in a 1-to-1 fashion to either placebo, that's a control arm, or vorasidenib given for up to 5 years, and we'll follow up then the patients to read out the primary endpoint of locally assessed PFS, and we'll also assess a number of secondary endpoints, including overall survival. We will enroll a total of 468 patients, so it's a large trial, and it will take 10.8 years until we reach the primary endpoint, so quite a long time. We will activate this study still in December. In Europe, we will open 33 sites in the ERTC network in Europe. We're collaborating with Cogno, so 10 sites in Australia will be activated, and CCTG, where also 10 sites in Canada will be activated over the course of the next months. The Lions trial, an extremely interesting trial going into the same direction as the Vigor trial, also asking the question of whether adding vorasidenib in the first-line treatment adds benefits. In this case, astrocytomas, IDH-Mutant, WHO grade 3 will be enrolled, and the randomization will be between placebo plus temozolomide after radiotherapy, or radiotherapy followed by vorasidenib plus temozolomide. A total of 408 patients will be randomized, again along study duration, and the primary endpoint also here will be PFS. And I understand, Dr. Galanis, please correct me if I'm wrong, that this trial is very close to being activated as well. Another point I would like to briefly discuss is how to optimally follow up patients on IDH inhibitors, such as vorasidenib. As you know, following up these patients, monitoring the disease by MRI comes with challenges. Low-grade gliomas are oftentimes not very well delineated and easy to measure and follow up on MRI. So I believe, together with my colleagues in Europe, where amino acid PET imaging is fairly well established in some parts, that this technique may add very much to improved disease monitoring, because also most of the low-grade gliomas can be depicted and visualized by amino acid PET imaging, which shows metabolically active tumor parts. And in this small case series of 5 patients, we performed serial PET imaging in patients treated with vorasidenib, and saw that in 3 of these 5 patients, we could, even as early as 5 weeks after starting vorasidenib, see responses and tumor shrinkage on amino acid PET imaging that was not measurable on MRI. And we're following up this quite interesting data in a prospective study called APPEAR at the moment. So something to think about for the future. There are also ongoing trials with other novel approaches for IDH-mutant gliomas listed here. Some vaccines, some PARP inhibitors, demethylating agents, and other immunotherapies. I will not go into details for the sake of time, but want to highlight that there's a lot going on with peptide vaccines, such as the Amplify Neovac trial, where a long peptide vaccine targeting IDH1 has been developed by the colleagues in Heidelberg, Michael Platten and Lukas Bunse. Some early clinical trials have reported immunogenic responses to this vaccine, and also some pseudoprogressions occurring in up to almost 40% of patients, indicating potential activity. And these early data are being followed up in clinical trials, such as a window of opportunity trial, which has closed the database already, and we're waiting for the data, but also a randomized trial, the STAR-VAC trial, will be launched in the course of 2026, where also the maintenance treatment of IDH-mutant grade 3 and grade 4 astrocytomas will be assessed with this vaccine in the randomized fashion. So in summary, IDH-mutant gliomas and the optimal treatment is a very dynamic clinical research field with a lot of things going on, so very exciting, including large randomized trial efforts on investigating maintenance of vorasidenib with or after radiochemotherapy, the trial run by Alliance and the other by the ERTC. The role of amino acid PET imaging for disease monitoring is something I think we should really assess given the limitations of MRI. And there are a number of novel approaches, such as IDH targeting vaccines and others. And with that, thank you for your attention. And I think we move on to the PKC.
Thank you very much, Dr. Professor. Indeed, the future is exciting. And thank you all for these very thoughtful presentations. So let's just put all this discussion we had so far into action based on an actual patient case that Dr. Peters will be discussing for us.
Yes, thank you very much. So this is a 34-year-old male patient. He's a chemical worker at a pharmaceutical plant. He's married, he has 2 children, and he was in his usual state of health until July of 2018 when he had a prolonged seizure. You can actually see that he ended up going to the emergency room. He got a head CT, which showed an abnormality, and then subsequent MRI, which shows this T2 flare hyperintensity. And this was his imaging before surgery. He then had surgery by one of our wonderful neurosurgeons. His ultimate, and you can see that he had what was considered a gross total resection. The diagnosis ended up being an oligodendroglioma, WHO grade 2, 1p19q co-deleted, and had a canonical IDH1 mutation.
Okay, so the patient comes to you after surgery. They had a great resection, as you saw. What risk category for low-grade glioma would you assign this patient? Low risk, high risk, somewhere in between, or you're unsure? Okay, 54% low risk, and everything else is divided. And here's a follow-up question, because we saw about 50% or about 30% of you were not clear. But here is the follow-up question. If you place this patient in high-risk disease, maybe I should say the 15% of all the patient was high risk, what was the biggest reason for doing so from the following options? Preoperative tumor size, neurologic symptoms, molecular characteristics, age, or another reason? So very important, very good answers, because these indeed are some of the characteristics we use to determine risk. But it's also very interesting to see how the specific characteristics would play in this case.
Yeah.
And I have to say that our risk definition is evolving. It is multifactorial. There's not one thing fits all in how determine the risk, but there are several factors we are considering. And maybe I'll go around and ask the panel here. In this particular patient, Dr. Peters, what is your assessment in terms of risk and why? This is important because when you see the patient after surgery, it's going to come down to deciding if you're going to offer to them a radiation chemotherapy approach. Are you going to offer to them a perhaps IDH inhibitor vorasidenib approach, which has been approved for grade 2 tumors, or you're going to perhaps just observe the patient? So this is where the definition of risk and thinking about some of these factors is important. So Dr. Peters, what are the factors you are considering and what will be your assessment in this particular patient?
So for this patient, really what was really, I think, critically important was the extent of resection. And when I think about, Sean's talk and the discussion of like gross total resection versus supramaximal resection. This is a very good resection. The surgical cavity, of course, I'm going to get another MRI to evaluate how it looks again farther down the line. So definitely extent of resection. And then the next is, what was the grade of the tumor, along with it being an oligodendroglioma with the 1p19q co-deletion. So those were two very key things for me in this case, and to really put him in a low-risk category.
Thank you. Dr. Prosser?
Yes, I would fully agree. A thing that we have not touched so much upon is the tumor grading. So in this case, the tumor was labeled as a grade 2 glioma. However, I think it's important to realize that the distinction between grade 2 and grade 3 is not that straightforward. And that's something that our neuropathology colleagues will probably have to work on in the future to make the distinction clearer on a histological level. But the molecular characteristics, of course, will help. But overall, I would have put this patient probably also in the low-risk category, realizing that there's always a gray area and room for different opinions.
All right, so let me reverse that for you. What would be certain characteristics that you would think about if you have a low-grade glioma patient comes to you after their surgery? You know it's low-grade glioma. There are no other characteristics. And for the audience, the CDK and 2A B homozygous deletion is an important molecular characteristic that will make the patient a grade 4 tumor, applicable primarily for astrocytomas. But if a patient comes and molecularly, it's clearly a grade 2, what are some of the characteristics that will make them a high risk and will increase the likelihood that would offer for them radiation and chemotherapy versus something else?
Yeah, I think the postoperative extent of resection is an important parameter, as well as the symptoms of the patients. So I think these are two key parameters that at least we discuss oftentimes in our molecular or our multidisciplinary tumor board to make the decision of whether to go more into the direction of radiochemotherapy or IDH inhibitor treatment.
So neurologic symptomatology due to the tumors and less than optimal resection would be factors that would make you more likely to recommend radiochemotherapy.
Correct, yes.
Wonderful. And here's our surgeon and to the board.
Yeah. So also let me say this. So in the, 2 now going on 3 large-scale epidemiology risk study papers that have been ongoing for IDH-mutant tumors, we're constantly asked the question during the review of how does this risk group 1, 2, and 3 line up with our standard EORTC or UCSF, whatever risk stratifier that we have published and available. And the truth of the matter is, in the modern era, it actually doesn't, right? It's just what we're talking about. I think, I agree with what everyone has said. Certainly extended resection is important. I would add to that, having looked at this data without publishing it yet, location of residual tumor matters. If you have residual tumor, residual disease in motor cortex, that will therefore, by definition, never be removed. Tumor medial to the lenticular striate arteries in basal ganglia areas, right, where the neurologic risk, stroke risk of removing this is a big deal. I think in these newer risk stratifiers that are evolving and will come out in the hopefully next year or so, location will be a part of that as well. This patient I would put in the low risk category. Again, age, good resection, and oligodendroglioma, but it's certainly an evolving field, just like we discussed.
All right, I'm about to ask a very hard question before we move on. You're the first one who mentioned the word age. So maybe I'll start with the other panelists. How does age factor in your determination of the risk?
It doesn't anymore. I think this is really key. I think that the older studies, when age was considered, this is before we knew and had the luxury of knowing whether they were it was an IDH mutant tumor or not. And so essentially those patients that were older probably had an IDH wild type tumor, and hence a glioblastoma. So I think we have to re-examine what age means for these patients. I do think that by virtue, when you get a little older, maybe age doesn't feel like it matters as much. Uh, but again, for now, based really, really the changing, shifting, it really did shift because of knowing the power of this IDH mutant protein and how it is different in these tumors. So I don't think age matters.
Okay, Dr. Prosser.
Yeah, not much to add. I agree, and that's probably the reason why we didn't mention it, as you pointed out, because symptoms, extent of resection, tumor size, and location appear to be more important for risk stratification than age.
And Dr. Harvard-Turber, what
Yeah.
are the circumstances in which you will factor in age in your decision making?
So again, I'm going to have to take my statistics hat off because what we're talking about are clinical tools that we make, but the calculation is actually a range. So I would actually say that if you use, for example, the RPA model or any sort of like minimally supervised, multivariate statistical tool, what you're saying is the age is broader, is what I think we're saying. The age is much broader than the narrow, like greater or less than 50 or something like that is in the prior. We know that's not correct, but is it greater or less than 70, greater or less than 80, right? And so, where will age then factor into the top 2 or 3 variables that therefore drive what this risk model looks like, right? That's what we do, right? We say which are the top 2 or 3, maybe up to 4 or 5 variables that drive risk. That doesn't mean age isn't there. It just means maybe it's 7 or 8 on the list, and therefore it doesn't add into our tool. So I think we just need to be careful about saying it's a yes or no. At least from a decision-making standpoint, when I see an 80-year-old with a presumed IDH mutant tumor or a non-enhancing tumor that's slowly growing in clinic, age does factor in, actually, in a good way, frankly speaking. And the point I make is, well, maybe you've won the game. Like, do I need to do anything here? Right? So I don't know that we can throw age out. I think it has much different context relative to.
So where this discussion also becomes relevant because age older than 40 traditionally, as you heard, was a classifier. We are all in agreement that that's not the case anymore. And reports in the literature regarding the impact of age are at the best conflicting. And basically what you're hearing is that there are other factors that determine prognosis and risk at a greater extent than age. So be sympathetic to your patients, independently of their age group. So what did you do about this patient, Dr. Peterson?
So this is sort of the next part of the case. So as I mentioned before, the patient had this T2 flare, hyperintensity, had a surgery, which we've all deemed sort of a gross total resection. And we followed him. He was, of course, he would come to clinic regularly. We would do MRIs. We did have to struggle with doing some seizure control for him. But really, within sort of 2 years later, he sort of had slow, measurable growth starting in mid-2021. And this is just an image. You can see that there's now more T2 flare hyperintensity. And if I was to show you some images maybe in 2020, you could see how that was slowly growing and changing for this patient. What next step would you prioritize for the management of my patient or this patient, this 34-year-old patient with a oligodendroglioma? Continued watchful waiting, radiation followed by chemotherapy, IDH inhibitor monotherapy, or second surgical resection followed by watchful waiting. So interesting. We have lots of different choices, but it looks like the majority would start IDH inhibition for this patient. But some people would consider radiation. Some would also, we have some surgeons that would continue to do them. And also the option of, there's a small minority continue to do watchful waiting, especially if they were asymptomatic.
What did you do?
Well, he was able to get into the Indigo study. So we enrolled him into the Indigo study. This was his MRI before trial entry. At that time, he was essentially on vorasidenib versus placebo. And you can see his MRI over time, February 2022 to July to September, and then most recently in July of 2025. And when we were able to unblind him after the data analysis showing that vorasidenib was superior in a blind independent review, he was found to be on vorasidenib. I will tell you that his seizures are now very well controlled. One of the things that we're trying to do now is to taper him down on his seizure medicines per his request, because he doesn't want to take them as much, and he's doing quite well and continues to work in his job.
The next question here is, what if this patient progresses on their IDH inhibitor? What what would you guys do?
Well, I guess it depends a little bit on how the progression looks like, what the location is, the tumor size, and whether surgical resection, for example, is again an option. So I would probably speak to my neurosurgical colleagues first and ask whether another resection is an opportunity, and otherwise I would consider radiochemotherapy.
I think there's actually going to be some abstracts that will discuss this actual point at this meeting, that will decide what is like what have people been doing after surgery. I think that, of course, this deserves a discussion at a tumor board. We want to get all parties involved, evaluate what is there. I think definitely doing a second surgery is a very reasonable option, as long as the patient is doing well neurologically, and can have a safe resection, and then consider radiation chemotherapy. It's nice to query the tissue again, to see that if it's become transformed or changed in any way. So again, I would have all the options open for our patients. And of course, per NCCN guidelines, I would always consider, if there's an opportunity for a clinical trial for this patient, would be to consider a clinical trial.
Wonderful. So a key message here is the multidisciplinary assessment of the patient prior to decision making, and all the options, both at the earlier decision time point and now, and the implications of the treatments we give or we choose not to give. And of course, here is our surgeon. You saw the MRI. What would you do if you were part of the tumor board discussing this case? What would you say?
Yeah, to me, the big question isn't what to do when if the patient progresses. It's when, right? This is a beautiful case, and illustrating in 2 years the growth trajectory of the tumor relative to the effective time of the drug, right? And how long are we willing to wait? And that ends up being the discussion at our tumor board a lot, is yes, we see evidence of growth. How long are we willing to continue IDH inhibition therapy as a, second monotherapy? And a lot of that depends upon the risk of surgery, if we think that will be the next treatment based on the location of the tumor. Here, if it doesn't work and the tumor grows another millimeter or two, the surgical risk would be about the same. So, but I still would love to hear, is it 6 months? Is it a year? I don't know that we'd wait more than 2 years, but that you have to draw the line at some point. And when that is very fuzzy for us. And it ends up being a very patient-specific decision in tumor board.
Correct, as well as the patient's willingness to come for the follow-up, to comply, other factors that are taken into consideration. And again, please do not forget about clinical trials.
Yeah.
We have a related question to that. The question is if anyone following resection would introduce again an IDH inhibitor.
Good question.
I think that is a very interesting thing that we continue to do. And this is why we're at this meeting, right? Because, as I mentioned before, there's going to be some abstracts really discussing what happens after patients do progress on this. And we're starting to see, those patients in the Indigo study did quite well, but what are happening to those patients that are now progressing? I think we need to really look at this and understand it. I think that there is a potential to study this in a clinical trial, in a way, in a clinical trial, and how that's designed. I think it'll be very important. I think we need to learn from studies like the cefusidenib study that was done by Dr. Whittle and colleagues about what happens to those tissues after they've seen an IDH inhibitor and understand what those tissues look like. So I think this is I my with the toleration of the drug is very well and you can get some effect, I would say consider it, but I think we just don't know yet, and we need to continue to do research and to learn from each other.
Yeah, I totally agree because for us, studying the tissue following failure in this inhibitor is going to be important to A, understand the mechanism, and B, understand if this is focal, clonal, or it's more diffuse. The whole tumor transforms into something else. Because if we think about other use of targeted therapies in oncology, take for example GIST and CKT inhibitors, for the ones of you who treat these tumors, if you have a focal progression, you treat the focal progression and you continue with the same systemic treatment. Well, for gliomas, we do not know that yet. So a key element would be for us to understand the extent of changes, of molecular changes and evolution following failure. And that I think is going to allow us to be much smarter as to how to treat. I mean, an example could be, for example, if you have just one area of focus, should one consider this localized treatment and continue with the IDH inhibitor? A lot to be learned from this long-term follow-up of the patients. There is a question I want to ask that relates to the fertility issue in these patients. So the patient in our case was married. Sounds like they were done with their families. You advise them on contraception, which is very important. What if this was a 34-year-old female patient who still wanted to have children? What would you advise this patient? If you can, please help us decide. Defer the IDH inhibitor, the family is complete. Start IDH inhibitor with contraceptive counseling. Refer for fertility preservation, followed by the above. Or do not use an IDH inhibitor because you're concerned about the impact on fertility. And as you can see here is the most common answer is refer for fertility preservation followed by the above. And I would agree that this makes a lot of sense, both for men and women, in order to ensure that if they wish to have children at some point during the disease course, and remember, our patients, depending on the grade of the histology, are expected to live 12 to 20 years. And it's very at the average. Now, hopefully much longer than this. But this is an important consideration. And being able to have children requires, again, appropriate fertility counseling. The one thing I want to also highlight is for male and female patients, contraception is important, but the importance of barrier contraception because of the interactions between hormonal contraception and IDH inhibitors that can result to lower activity and effectiveness of the hormonal contraceptive methods. I think we're going to have time for only one question, which the audience has already sent, and I want to cover that before we conclude. I think it's a very important question. So how are we thinking about grade 3 or 4 tumors? Are there any circumstances in which we would currently recommend an IDH inhibitor outside the clinical trial? And I will start with Dr. Prusas.
It's not covered by the approval, at least in Europe not, and therefore clinical routine I would say no. But having said that, there are some patients that have been treated also by myself with grade 3 tumors when it was still possible in an early access program. And there we did also PET imaging and saw that grade 3 tumors showed the same types of responses as grade 2 and 2 tumors. So I do think that these tumors are in principle responsive, and we need to build more knowledge and more data in each trial.
No, and this is such an important point. A lot of you have seen the results with use of both vorasidenib and ivosidenib for recurrent high grade, where the results did not suggest significant efficacy. Nevertheless, recurrent grade 3 tumors are not necessarily the same thing as a newly diagnosed grade 3 tumor. And this is where also the studies are happening, the clinical trials are happening for patients with newly diagnosed grade 3 tumors. Now, you heard Europe, Canada, US, Australia. If you have an IDH-mutant patient, I think with newly diagnosed, our first consideration is to put these patients in clinical trials so we learn more, and we hopefully are able to use these inhibitors when they're the most effective, and this is at the time of diagnosis, also for higher grade. Dr. Peters, agree with that?
Yes, I agree. I mean, you took clinical trial off the table. I was going to say clinical trial. But I know. Right. So I would really encourage people to, participate in clinical trials. Remember also that these patients are long-term patients. I've been practicing for several years now, and a lot of the patients that, I started with are still my patients that have these kind of tumors. So there's opportunities in clinical trials for both patients that are newly diagnosed that are appropriate, and also recurrent patients. And Dr. Prusser really detailed a lot of those scenarios where there are clinical trials for recurrent patients, but then also patients that have already gone maybe through radiation and chemotherapy, that now have completed their chemotherapy adjuvantly. There are studies like the safusidenib study where that's an add-on therapy afterwards. So I think there's now an opportunity for us to answer all those questions, but it's going to take some time to get those results. I was looking at the slides and I was thinking this is going to take years to read out. But I think what's exciting is hopefully we'll all still be here and we'll continue to learn about those results. And really, I would say 5 to 10 years from now, I hope we're continuing to have these discussions, and maybe we're talking about, what's the best combination for the future.
Correct. Maybe we can talk about doubling the survival. We have already doubled with the conventional technique. So let's make that our goal. So I want to thank you all very much for being here today. Thank you all very much, and have a great meeting.